So, good afternoon to one and all present here, and welcome to your favorite channel in understanding cancer, Cancer Reach. Cancer Reach is an initiative by our very own healing hero, Dr. Krishnamani, to spread awareness about cancer and help patients and caregivers access the right treatment at the right time. Today, doctor is going to discuss two cases of breast cancer with us, which were treated under his supervision, so we can have an idea of the real world scenario of how the diagnosis, treatment plan, and management takes place for a breast cancer patient. Without much further ado, I'll quickly introduce our doctor so we can begin with the session. Dr. Krishnamani completed his medical graduation in 2005, his post graduation in 2010, and specialized in medical oncology in 2014. Since then, he has continually expanded his knowledge and skills by completing fellowships from prestigious international institutions. Dr. Krishnamani has been actively involved in academic contributions and professional development. Currently, he is working at American Oncology Institute in Hyderabad. A very warm welcome to you, sir.
Hello and welcome to Cancer Reach. Thank you.
So, sir, how do we begin with today's case? You're going to discuss about two breast cancer cases with us.
Yeah.
How
So
do you start?
the reason we chose this is we've always been having a discussion on what the symptoms, signs are all like. So we wanted to have a real world discussion and an interactive kind of a session. Okay. So breast cancer is the most common cancer which we see amongst women in the world or in our country also. So it's a highly treatable cancer, and it's a cancer which can be detected early because it presents as a lump in the breast most of the time, right? So we wanted to focus more on this cancer and some real life cases of how people come and what should be done. Okay. So first, I would start with a lady who is 55 years, who has no comorbidities, that she's not diabetic, she's not hypertensive. She comes with a lump in the breast, and she has this lump for almost 3 to 4 months, which is slowly growing in size. She has not sought medical opinion for this. Got it? So finally, she tells one of her family members, her daughter, and they get her to the hospital. So the thing is, you have a lady who is fit, who has no health issues, comes to you with a breast lump of a 4 month duration. There is no family history of breast or ovarian cancer. Why? Why do we ask this? Because if you have a family history, you may carry this BRCA1, BRCA1 or BRCA2 gene. So we ask, not that everybody should have, but if you have a strong family history, you may have BRCA or BRCA2. So she doesn't have any family history. So the question is, how are we going to proceed?
Yes.
So you
So,
asked
sir,
me, yeah.
in the first appointment itself, like you know that the patient is having a lump without any associated symptoms. Is that correct? No other symptoms, just the presence of a lump since past 3 to 4 months. Okay. Okay, sir. So
So
then how
if
would
you,
you proceed?
if you are the attender of a patient, what would be your line of thinking? Imagine you are the sister or daughter or friend. What would you ask?
So if it is a lump in the breast, then definitely the thought would go to, maybe it's a breast cancerous lump. Um, but then also because there is no other family history, like the mother's not had it, or there's no history of cancer in the family, they might even think it could be like some fibrous mass which could be removed because that is also quite common amongst women nowadays. So
So very good. Any lump in the breast is not equal to breast cancer. Okay, lump in the breast doesn't mean you have breast cancer, but all breast cancers usually have lumps. So if you have a lump, it could be fibroadenoma, fibrocystic disease, breast cancer, etc. What you should do a needle test, which is called a biopsy, to prove it is cancer. So she comes with a breast lump. If you ask me prima facie, is it cancer? I will say no, I don't have proof. It looks like maybe cancer. So first what I'm going to do is I will physically examine the patient. I will check for lymph nodes here. Sometimes the cancer can spread here. I'll check for the lump. I'll check how the nipple is, whether it is indrawn, whether there is bleeding, whether the skin over the breast is completely involved, whether the armpit lymph nodes are palpable. Okay, whether the patient has jaundice, that means it's probable liver involvement. Whether she has severe back pain on the spinal cord, that means probably bone involvement. So I will physically examine my patient. I will take the complete history and physical exam. Then we will do an X-ray of the breast called a mammogram. Mammogram will have a scoring 1 to 5. 1, 2, and 3 are usually benign. 4 and 5 means it could be cancerous. So that is when you will do a biopsy. So if the mammogram is suggestive that it is BIRADS 4 or BIRADS 5, then you will plan a biopsy. So suppose the mammogram says it's a BIRADS 2 lesion, that means it is a benign lesion. You will say, come back to us 3 or 6 months later with another ultrasound. But if it's a BIRADS 5 lesion, then you would say, or a BIRADS 4 lesion rather, you would say it is suspicious of malignancy. Get a biopsy done. It is a needle test. It is done in the office. It is not an operation. It is done in 5 to 10 minutes. Report comes in 3 to 4 days. It will tell you whether you have breast cancer. As we have already discussed on Cancer Reach multiple times, if it is breast cancer, you have to do ER, PR, HER2 on the tumor.
Correct,
So
sir.
I will do a history, physical exam to clinically confirm, then do a mammogram, then do a breast biopsy for ER, PR, HER2. Now, 4 days later, you come, I say, yes, this lady, your friend, has breast cancer. Then what is your next thought process? As a family, what will you think?
Sir, additionally, would you recommend any blood tests to the patient
I
along with
have
these other
already,
tests?
yes, we've always discussed on Cancer Reach. We do tests for the general physical health of a patient, which is the complete blood picture, kidney function, and liver function test. So when you
Yes.
talk about cancer, what all you are going to do, I will do test to diagnose my disease with this biopsy. I will do test to stage my disease. That should be your next question. What is the stage of my patient? Staging is done with a CT scan or a bone scan or a PET CT scan or ultrasound X-ray. So I will do next step is biopsy is done, mammogram is done. I will do staging in the form of either X-ray, chest ultrasound or a CT or a PET CT. I will do blood tests to know the general health of a patient, which includes complete blood picture, kidney, liver function test. If you are a diabetic, maybe fasting, HbA1c, postprandial sugar, thyroid profile, lipid profile. This way, you are saying you have breast cancer, ERP or HER2, stage, and basic blood test. Also, you will probably do a small heart test called 2D echo to look at the heart function. Okay. Anything else? Then what?
Listen, as you said correctly, the staging of the cancer.
Great. So now this lady, we did all this. So the biopsy came as infiltrating ductal carcinoma, that is breast cancer. ER-PR HER2 came as ER-PR is strong positive, HER2 negative. ER-PR is estrogen receptor, progesterone receptor. If it is strong positive means it's a good disease. It is hormone sensitive. We have discussed this. So she is ER-PR positive, HER2 negative. Then we did the PET scan. PET scan shows it's a 2 centimeter lump in the breast. There is no spread to the lymph node. There is no spread anywhere. So finally, early breast cancer, probably stage 2. Okay, stage 1 or stage 2, early breast cancer, no spread anywhere, strong hormone positive, HER2 negative. So what do you do for this patient? So this is an early breast cancer. You will go for surgery. And this is hormone positive. That is it. So the same scenario, I will put it different. If it is a 4 centimeter lump or this is 2 centimeters, make it 3 centimeters. 3 centimeter lump, all negative, triple negative. Then you will not do surgery first. Triple negative is bad disease. Triple negative, you give chemo and immuno first, not surgery. So there I would say I will give chemotherapy first, immunotherapy first, shrink the disease, take you up for surgery. Both are early, both are curable, both are treatable, but one is hormone positive, HER2 negative, one is all negative, triple negative. Triple negative is bad. So here you delay surgery. You give chemo first, immunotherapy first. Here there is no role of immunotherapy in hormone positive. You give surgery first. After surgery, hormone positives, they don't respond that well to chemotherapy. That's why in hormone positive, HER2 negative, if it is smaller in size, if it has not spread to lymph nodes, you will do surgery first. Then, if required chemotherapy, or directly go for hormone therapy.
Okay.
So, for our patient, we did surgery. It came as 2.5 centimeter lesion, T2N0. Complete breast was removed. So, there is no need of radiation. When do you give radiation? If tumor is more than 5 centimeters, if it is lymph node positive, or if you have saved the breast. Here we remove the breast, no need. No lymph nodes, no need. Tumor is less than 5, 2.5 centimeter, no need. So no radiation. Surgery done. Stage 2, early stage. She is hormone positive, so you put her on hormone tablets. One tablet a day for 5 to 7 years.
For 5 to 7 years.
Okay. Daily once with a calcium tablet. Now, will you give chemotherapy for this lady is the question. So there was a time in the past when we used to give chemotherapy. Now what we do is you send the tumor for additional molecular testing. If in the test it comes as high risk, you give chemo. If it comes as low risk, you don't give. Got it?
Okay.
So what I want you to understand from this is, or people to understand is, in breast cancer, you will do a biopsy first. You will do ER/PR HER2. You will do staging with scans. Patients come with the lump in the breast, ask for family history. ER/PR HER2 is good disease, triple negative is bad disease. Okay. If you are ER/PR positive, HER2 negative, if it is a small tumor like this lady, go for surgery. Triple negative or HER2 positive, go for chemo. And if the disease has not spread anywhere, surgery should be an option either now or later. Got it?
Okay. Yes. And so was this patient given the chemotherapy?
No. So we
No.
sent for her gene recurrence test that came as low risk. She did not need chemotherapy. She was put on hormone tablets.
Okay. And how is the prognosis so far for the patient, sir? Like,
Generally, the prognosis is 5-year survival is almost 100%. She is
okay.
doing very well. How do you evaluate? Every 3 months, she comes to you for the first 2 years. After 2 years, she comes every 6 months. After 5 years, she comes once a year.
Okay.
That 3 months, you will do a history physical exam. That 6 months, again, you will do physical exam history. Every year, you will do a mammogram of the opposite breast. Or if you have retained the breast, you will do a mammogram of both breasts. You don't need PET CT or CT scans unless you are suspecting recurrence. So post-treatment, how should patients follow up? First 2 years, once every 3 months, then once every 6 months, up to 5 years, then yearly. And every year do a mammogram. You are losing weight, you are breathless, there's water in your lungs, you have severe back pain, you're having a lot of headache, double vision, you have seizures, you have weakness that involves brain or the spine or the lungs. If these symptoms are there, your doctor will ask for a CT or a PET scan during follow-up. Otherwise, regularly it is not required.
Okay. So the prognosis for this patient was very good from
He is
what you
very
have said, and no recurrence also
till now. If
till
I
now.
complete 5 years, I will call her cured or cancer-free.
Okay. Okay, fine. And sir, any other notes that you want to add for this patient's particular case?
That's also what bottom line is. All of us should understand, sir, how is my mother going to be? That question's answer is based on first her fitness, Is she a diabetic? Is she hypertensive? Is she heart patient? Is she kidney patient on dialysis, a bypass patient, etc.? If you have no, you're going to be good. You smoke, you drink. If you have none of those problems, you're going to be good. Second stage. Stage 1 is good, 2 is good, 3 is not that good, 4 is not curable. Finally, ERPR HER2. ERPR positive, HER2 negative is best, triple negative is worst. So my prognosis depends on my general health, my stage, and my ERPR HER2 status.
Okay, sir. So then do we begin with the next case?
Correct. So now I will give you a scenario. We have a 35-year-old lady. She comes with a breast lump. She has a strong family history. Mom has breast cancer. Mother's younger sister has ovarian cancer. That kind of a family history. She comes with a breast lump and she comes with double vision, okay, and some headache. Okay, so how do you want to approach? What do you want to do?
Sir, like how we did for the first case, we will definitely go for the biopsy first and then the scans for the staging. Um, Probably because she's having blurred vision, headaches, could be sign of metastatic disease
The
also
brain. So
for
that's
the
why for
brain.
brain
Yes.
always do an MRI.
Okay.
PET scan or CT scans are not great for brain. Do an MRI brain with contrast. So now she is biopsy positive. She is triple negative. She has multiple brain mets.
Okay.
So what stage it is? Stage 4. Why? It has spread to the brain. From where? From the breast. Is it good? No. Why? Because it is already spread to the brain and she's also triple negative and she's a young lady. Because she has a strong family history, you send her blood for BRCA1, 2 and she's BRCA positive. That means she has a gene which is running in the family causing breast cancer. How do we treat? So the first and foremost thing is here the treatment is not for cure, it is for palliation. It is to control her symptoms and to prolong her life, to improve her quality of life. So we are going to tell her family and her, I'm not going to cure you, I'm going to palliate your symptoms. We will reduce your disease, control your disease, improve your quality of life, and thereby prolong your life. Medicines don't enter the brain. So for the brain, first you have to give radiation. Because if you don't give radiation, the disease will increase. She may have problems because of that. So this breast lump is not priority now. The brain is a priority. So first you will start her on steroids, some and immediately on radiation to the brain so that the brain mets are controlled. After that, because she is triple negative breast cancer, you will give chemotherapy or immunotherapy. I'm not going to talk about the drugs, but what a patient or a family should understand is this is going to be an up and down battle. It is not that your disease will be cured and your surgery will be done and it will become zero. There is no role of surgery to the breast here. There is no role of surgery to the breast here. Here, the disease is going to have an up and down kind of a cycle. I give chemo today, the disease after radiation is done to the brain. So the patient is fine now. You give chemo, the disease will come down. After a few months, it will be stable. Again, the disease will go up. Again, at that time, you have to give some sort of chemotherapy. This is called first line chemo. This will become second line. This will become third line. Once you move from one chemo to another, the response of the chemos keep coming down. Also, your general condition will come down. You will not be able to tolerate intensive chemo again and again because your body is already exposed to a lot of prior chemotherapy. So bottom line, nothing goes into the brain. So first take care of the brain by radiation. Triple negative is a bad disease. So finish the radiation and start chemo or immunotherapy and immunotherapy. It is not curable because it is stage 4 and the prognosis is poor. Because she has BRCA positive, screen the other family members for BRCA so that you can prevent breast and ovarian cancer in those people.
And sir, when we talk about triple negative breast cancer, are there any molecules which are showing a better improvement for the patients as compared to the previous year molecules?
Correct.
Any
Immunotherapy
improvement?
shows very good results, especially pembrolizumab. So if you have, we do a score called PDL1 on the tumor. If your score is more than 10, you should get immunotherapy. Triple negative patients generally respond to platin drugs, cisplatin, carboplatin. They generally do well. And BRCA positive patients receive a drug called olaparib, which is a tablet. So in triple negative, you have three things which have come up. One is for BRCA, you have olaparib. One is platins, which we have been using for a very long time, cisplatin, carboplatin, and immunotherapy like pembrolizumab. Other newer drugs which have come are TDXT, which is Enhertu, in HER2 low tumors, and a drug called sacituzumab. So these are called antibody ADCs, antibody cytotoxic agents, dependent cytotoxics. So what these drugs do is they are linked to a chemotherapy molecule. They go into the system and release the chemotherapy molecule. They are a new technology, ADCs we call. So in triple negative, these are the advancements being made because it is such a bad disease and the survival is so poor.
And especially in this patient, you have stressed that she's a younger patient. So will the disease be more aggressive as the
And
time progresses?
clinical practice, we see young people have more aggressive disease.
So the prognosis definitely going to be bad for this patient.
Very bad.
And
So compared to the first patient who is hormone positive, stage 2, no spread anywhere, excellent prognosis, surgery will be done, 5 years survival 100%. Here, bad disease, triple negative, young lady, brain spread from day one. That's a bad.
could the patient have done anything to come a little earlier? Because the patient has come to you at a stage where the symptoms were have reached the brain already. So,
Any lady who has a breast lump, please seek medical advice. It could be fibroadenoma, but seek advice. You have nipple bleeding, seek medical advice. Indrawing of the nipples, seek medical advice. You have skin changes on your breast, seek medical advice. You have a swelling in your armpit, seek medical advice. You have unintentional weight loss, loss of appetite, headaches, fits, weakness, jaundice, because that is liver involvement, breathlessness, because water may accumulate in the lungs. Any of these unusual symptoms, tremendous weight loss, tremendous loss of appetite, tremendous loss of stamina, go and show. Chronic symptoms, things are lasting for more than a month or two. Don't ignore it saying that it is simple acidity or simple asthma, allergy. Any symptom which is prolonged, don't neglect. And a breast lump should be, see, breast lump can be easily picked up. It's not a tumor in your stomach or in your food pipe. So when you have a breast lump, you should pick it up. You should go. Many people, many women, even today, because of shame or because it's a private part or a private area, they don't even tell their spouses sometimes. They wait until it becomes big enough. No, cancer is curable if detected early. Let us understand this mantra.
yes, sir. Sir, any closing or parting remarks that you'd like to add for both of these cases combined
So
for
what
our
we would
audience?
usually tell our patients is again, breast lump should not be ignored. It is a commonest cancer, presents as a lump. Seek medical attention. Stop smoking and drinking. Okay. And you have a family history of breast cancer. Be aware. Seek medical attention. And breast cancer is not the same in everybody. Somebody can be hormone positive, which is a very good disease. Somebody is triple negative, very bad disease. Early breast cancer, curable. Advanced, not curable, but definitely lifespan is much, much better than a pancreatic or a gallbladder cancer. So bottom line is breast cancer present in any which way. And it being such a common cancer, we must be aware of the symptoms of breast cancer.
Okay, sir. Thank you for sharing these two cases. I'm sure the audience would get like a real world scenario as to how, when a patient walks into the clinic, how the diagnosis is made and what treatment plans, how the staging is done based on that, how the treatment is scheduled for a patient, and what would be the prognosis for both of the situations now. Thank you for sharing such a scenario with us, sir.
Thank you so much.
Yes, sir. Thank you for
Bye.
today's
Have a
session,
nice
sir.
weekend. Thanks. Bye.
Yes.